Thank you, everyone, and thank you for joining. For everyone that is with us here and as people continue joining, welcome to our final webinar of the year. We expect this to be the final one of the year as we plan for the next year's webinars. For us, this is the Hardest Clinic. The Hardest Clinic is a digital health non-profit organization focused mostly in telemedicine and global health education. And more so, we work in different programs in Kenya. Currently, we have 5 programs. We have the telemedicine program that, as you see, is hosting this webinar. We have the global health education that we link with different institutions around the world. We link with Vanderbilt University and Pittsburgh University and Kenyatta University, and the plans to link up with other different universities around the world. The third program is the HIV program that we work on adherence in different areas of the country, and mostly centered in the western part of Kenya. The fourth program is the Mother and Child Health Program that is in the IDP camps in Beledweyne and Mogadishu. That is the Somalia part of Kenya. And this part we deal with public clinics and mobile clinics and maternal and child health care. And then the fifth and the last program is in the coastal region. We call it the Girls and Mothers Safety Program. We previously called it Girls Health and Safety Program, but we realized that we encompass even mothers. So our plan is to host you on this webinar, ask questions on the chat box or the Q&A area. Please, we request that you be interactive in any way. With us, we have John, Professor John, our ED, Executive Director and our founder. As you all know, we have previously always told you that we were founded in 2011 with a focus on telemedicine, but we saw that our work was needed in different areas of the program, and that's why we branched to different programs. But all in all, we focus on digital health and global health. And that's how we pride ourselves as the Hardest Clinic. With us, we have Mirriam, who is a lecturer in Kenya Methodist University, focused in midwifery, and that's why we found it important to have her on board since she has worked in different hospitals. She has trained different clinicians and nurses in different areas, and mostly in the clinicals and deliveries and maternal morbidity, and mostly in labor and delivery areas, focusing mostly in East Africa. So as you see, sometimes the slides might be focusing in Kenya, but the context is fully on the East African part. Sorry for that. And we welcome you all. Questions are welcome. And then I will give Mirriam the room to introduce herself and then take over as she presents the slides. We are sorry, Dr. Paul.
And Dr. Paul has joined.
I joined. I'm sorry. I was I actually was doing telehealth with people here, and they finished a few minutes late. I'm sorry for being a little delayed.
No problem, Dr. Paul. Thank you. You joined. We have Mirriam, we have Dr. Paul. The duo today will be taking us on diagnosing and treating maternal morbidity during delivery. And Dr. Paul, we broadened our scope and focused on East Africa. And I informed Mirriam on the same, and she told me that the slides will encompass the whole of East Africa. So there's no problem. For everyone that has joined us, Paul,
and I've only worked with Mirriam, and I haven't had the pleasure of meeting her, and I'm looking forward to hearing from her. And she's going to present today. I'm just going to be here to try and answer a few questions. I'm sure she knows a lot more than I do about this. And then if we have to do any research, of course, we'll get back to everybody.
Thank you. Mirriam, if you are comfortable, you can take over.
Okay, thank you, Anthony, for letting me present. Good evening, good morning, good afternoon to everyone. My name is Mirriam Kivuva. Anthony Kimbadi has already said a lot about me, so I don't think there's anything else that I learned. But I'm a nurse and also a lecturer at Kenya Methodist University. Reproductive health is an area of interest to me, and basically that's why I found it so important for me to be able to present on this in that it is an area that is close to my heart. And also looking at the landscape, I'm ordered to speak on a topic that is one of the most urgent public health priorities in Kenya and also in East Africa. Diagnosing and treating maternal morbidity during labor and delivery is very, very critical in that when you look at our sustainable development goal, it is one of the key things that we want to address so that we're able to achieve that by the year 2030. And by looking at that, you can see we are just 5 years to 2030. So 2030 is there with us and we have a lot to do before that 2030 basically comes. So in today's presentation, we'll be able to explore the causes, the recognition, the preventive strategies, as well as the treatment approaches, as well as the systemic challenges that that affect maternal mortality and morbidity, with a focus in Kenya as well as in East Africa. I will also be highlighting the ongoing innovations that are taking place so that we are able to improve the maternal outcomes in our healthcare system, that is both in Kenya as well as East Africa. It is also worth noting that behind every maternal death is a family forever changed. Children lose their mothers, communities are losing their leaders, and the country is losing potential. So just as I said earlier, with less than 5 years to the 2030 Sustainable Development Goal, a lot needs to be done. And it all starts with me and you. So I think we can begin my presentation. So when we look at the Kenya maternal health landscape that is presented before us, we can see right now, the maternal mortality ratio is at 414 for every 1,000 live births. So when we compare this with our global target of having 70 maternal deaths for every 1,000 live births, you can see we are far away from achieving whatever that we want to achieve in terms of maternal mortality, whereby we want to achieve less than 70 maternal deaths for every 100,000 live births. And then you can see that the majority of the maternal deaths originate from postpartum hemorrhage. When we talk about postpartum hemorrhage, simply we are talking about bleeding, vaginal bleeding that occurs after delivery of the mothers. And that's why basically the period after delivery is very, very critical because as you can see from research, most of the maternal deaths occur after delivery, especially in the first 24 hours. So that is a very critical period for us as the healthcare providers to ensure that we target that period so that we're able to reduce the maternal deaths. Then first, following closely is hypertensive deaths that account for 21%. And so basically for every mother who dies, 20 to 30 others survive with severe complication or near-miss events. So basically 64% of these severe complications begin before even a woman reaches a healthcare facility. And now there is where we need to address our 3 delays, whereby our first is usually delay in seeking care. The second delay is the delay in reaching a healthcare facility. And then our third delay is delay in receiving care. So in the delay in seeking care, basically occurs due to socio-cultural or economic challenges, especially at the home environment. Delay in reaching care, which is our second delay, most occurs due to transition between the home environment to hospital environment. Then delay in the receiving care most occurs due to the systemic challenges that occur in the healthcare setting. Thank you. You can move to the next slide. Thank you. You can move to the next slide. So when we look at the leading causes of maternal mortality in Kenya, we know that postpartum hemorrhage or obstetric hemorrhage is the one which is the main cause of maternal deaths in Kenya, the leading cause. And basically these causes of maternal hemorrhage are usually linked to the postpartum hemorrhages, whereby now postpartum hemorrhage occurs due to the 4 T's. When we talk about the 4 T's, we are talking about trauma, whereby maybe our mothers are getting tears, they are getting cervical tears, uterine rupture, etc. When we talk about our second T, we are talking about tissues, whereby our mothers can be having retained tissues of conception, the placenta, the membranes. Then also we can talk about them. We can also talk about the third T, which can be thrombin, whereby our mothers may be having clotting disorders that can expose them to excessive bleeding, among others. Then hypertensive disorders in pregnancy also contribute to these maternal mortalities. When we talk about the hypertensive disorders, we are mainly talking about preeclampsia and eclampsia, which are the main causes of maternal deaths. We can also talk about sepsis. or the sepsis that can result from the unsafe abortions, can also be having obstructed labor, which can also basically occur due to issues with the passenger, and also, sorry. So which can occur due to issues with the passenger or the passenger. Maybe in this case, we are talking about a mother having a normal pelvis, and basically the baby is bigger than the pelvis. We can also be talking about a pelvis that is normal size, but the baby is big, or the baby is of normal size, but the pelvis is inadequate. Or we can be talking of both of them occurring together, what we call the catarrhopelvic disproportion. So this, for us to address these causes, means that skilled birth attendance is very critical, especially during the period of delivery. When we talk about the skilled birth attendants, in this case, we are talking about having the necessary healthcare providers with basically in the right numbers, them having the necessary skills, and also being an enabling environment that has all the resources that they need for them to provide basic and also comprehensive emergency obstetric care. Next slide. Anthony. Thank you. So when mothers come to the healthcare facility, we as the healthcare providers need to be competent enough for us to be able to pick risk factors that can predispose them to complications. In this case, we are talking about obstetric history. When we talk about obstetric history, there are any risk factors that can be linked to pregnancy. These issues are issues like previous cesarean section. For example, if a mother had a previous cesarean section, this can predispose this mother to a uterine rupture because already they have a line of weakness. For example, if we have history of postpartum hemorrhage or retained placenta, there is a risk of recurrence of the same. Multiple pregnancy also poses a risk of them having cord prolapse, cord presentation, excessive bleeding due to that of a distension, and also laxity of the uterine muscles. And also mothers with bad obstetric history where they have previous losses or complications, there is a risk of recurrence. Another issue that complicates pregnancy in mothers are also issues such as medical conditions in pregnancy. And that's why we usually encourage that in our routine antenatal care visits, we need to schedule more visits for these mothers who have medical conditions such as diabetes, cardiac disease, or hypertension, so that we are able to be more keen and also be able to seek issues early in time before we get complications. Then also in that we're in low and middle income countries, we also have mothers experiencing social factors whereby they may have pre-existing conditions such as anemia. And these ones can be linked to their social environment such as poor nutrition, infections during pregnancy, such as malaria, which can predispose them to anemia. We have them having TB, among others. So it means that we as the healthcare provider, during the antenatal care period, we need to be very keen so that we're able to pick out these issues. And currently, we are recommending that the least visits should be at least 8 antenatal care visits right now, 8 antenatal care visits, so that at least we're able to pick these issues in time. And then you realize that in the Kenyan context as well as East Africa, most of our mothers come in the second trimester. They don't come in the first trimester, but we really encourage these mothers to come as early as in the early trimester, as soon as they realize that they are pregnant, so that at least they're able to bridge this gap. So next slide, Anthony. So just as we have said, early detection is able to save lives. So we are encouraging our mothers to come as early as possible, as soon as they realize that they are pregnant, so that we're able to pick up issues in good time. And also remember that we're also recommending early ultrasounds currently, so that we're able to pick issues early before these mothers even progress to their second trimester of pregnancy. Next slide. So the next thing, we as the healthcare providers need to be competent enough and be able to pick the cues in good time, so that we're able to save the life of these mothers. So when we talk about the hemorrhagic complications, remember that we say that is the leading cause of maternal mortalities in Kenya as well as in East Africa. We should be able to basically diagnose it in good time. When we talk about hemorrhagic complications or hemorrhage, or basically postpartum hemorrhage, where we have excessive bleeding. If it is vaginal, it is more than 500 mils. If it is cesarean section, we are talking of amount that is above 1,000 mils. Or in some cases, we usually talk about any amount that affects the hemodynamic state of the mother. So we as the healthcare providers, research has shown that we usually underestimate the amount of blood loss that our mothers lose. And that's why you find that our mothers sometimes get into shock, even without even us realizing. And that's why recently we have come up with an innovative approach whereby we are talking about the use of the calibrated grapes, so that we are able to at least estimate the amount of blood loss correctly. so that basically we don't underestimate and our mothers get in shock without us realizing. Then when it comes to hypertensive disorders in pregnancy, in this case, we are talking about preeclampsia, eclampsia, or gestational hypertension that comes as a result of pregnancy. We, the healthcare providers, need to be able to pick out the warning signs, such as the severe headache, the visual disturbances, the epigastric pain. And also in the routine guidelines currently in Kenya right now, we are recommending that as our mothers come for every visit, we are recommending that we, the healthcare provider, should be able to do a urinalysis. We should be able to track the blood pressure readings. And if the blood pressure readings are above the normal range, we usually recommend that you add additional visits for this mother so that you're able to pick up issues in good time. So when it comes to obstructed labor, now this is where the nurse and the midwives come in. As you monitor those mothers with the pathogram, you should be able to monitor them appropriately and not when they are not progressing. Not when this mother is basically, we don't want to reach a point where we're having abandoned ring. That is a late sign of obstructed labor. You should be able to pick it early, where you see that this mother is not dilating, the fetus is not descending, and you should be able to pick that even before the mother gets abandoned ring. Because the moment we're having abandoned ring, it means that all is not well. We are getting into basically impending uterine rupture, and we should not reach that point. Then also we have infectious complications that can arise also during the process of labor and delivery. And in this case, it is with the healthcare providers. We need to adhere to the necessary aseptic techniques to ensure that basically our mothers are not getting the nosocomial infections when they come to healthcare facility. Then after delivery, we need to monitor them keenly so that we're able to pick any signs of infection, such as a fever that is above 38, lochia that is false smelling, among others. Next slide. So we have the essential tests that aid in diagnosis, and this form part of the antenatal care profile that we do for mothers routinely during the antenatal care period, so that basically they don't complicate during the time of delivery. So we recommend that we do the routine blood pressure monitoring so that we're able to pick the eclampsia, the preeclampsia, and also the gestational hypertension in good time. So we also do the complete blood counts. For example, if the mother is having an HB of less than 10, basically we're able to pick it in good time. Elevated blood count, which can be suggesting infections, we're able to pick that in good time. We also do it so that we're able to know the blood group of the mother and also the rhesus factor so that we're able to rule out issues such as rhesus incompatibilities in good time. Then also we are recommending, at least currently in the Kenyan context, at least 2 ultrasound, and the first ultrasound we recommend it to be as early as possible so that we're able to pick these issues in good time. We don't want you to progress up to the second trimester, and at that point is when you are telling the mother that the pregnancy is not viable. So we need to be doing it early so that we're able to detect complications in good time, and also we are able to address the mother's issues in good time. Then also we would do routine blood cultures, vaginal swabs, among others, so that we're able to rule out infections. Then also in the malaria endemic areas, you should be able to test for malaria. Then remember, we also do the hepatitis B test. We also screen for TB, among other tests in the Kenyan context as well as East African context. Then the next issue that we want to look at is what can we do within the spaces we are in to prevent these mothers from getting complications and also them getting maternal mortality. There's a lot that can be done. Number one is early risk identification. And in this case, we're encouraging our mothers. Can they come early as they realize that they are pregnant, so that we're able to track issues in good time, screen for issues like anemia, hypertension, infection, and other risk factors, and then we're able to give timely interventions. Then also, we can also use prophylactic interventions, whereby currently we recommend iron and folate supplementation so that we're able to correct the anemia as well as prevent the neurotube defects. In the malaria endemic areas, we also give the malaria prophylaxis in the second trimester. Then also we want to do the active management of that stage of labor using oxytocin, or you can use carbetocin in the remote areas whereby we have cold chain issues. Then we also have seizure prevention, and this one is usually done for patients who have severe preeclampsia, and usually do it using the same protocols and the dosage and everything just like in eclampsia, so that we prevent our mothers from progressing from severe eclampsia and them getting eclampsia, which is not good. Then the other thing that we cannot overemphasize is skilled attendants. In skilled attendants, we are talking about the healthcare providers having the necessary skills, knowledge, and also being provided with an enabling environment that has the necessary resources so that they're able to provide the basic emergency obstetric care as well as the comprehensive emergency obstetric care as well. And then the other thing now falls on the mothers, where now we need to ensure that our mothers have emergency preparedness. And that's why we recommend that during the first visit when a mother comes to a healthcare facility, it is your role as the healthcare provider to ensure that you teach them about having an individual birth plan. Now, in an individual birth plan, we are talking about them having chosen the nearest facility where they can deliver, have some money or have an insurance fund in relation to the same. We also ensure that at least they have selected a blood donor just in case of bleeding, among other factors. So can we ensure that we are teaching our mothers and emphasizing this every visit they come? Next slide. Then when basically we have issues, every second counts. So we should be ensure, for example, if we're having hemorrhage, we should ensure that we are using the evidence-based interventions to curb the same. So like administering enterotonics where we are having excessive bleeding, we can do the bimanual uterine compression, can do the uterine balloon component, or we can do the hysterectomy depending on how your patient presents. In managing hypertension, especially the severe hypertension, we can use drugs like hydralazine, labetalol, among others. In infections, we can use the broad spectrum antibiotics. Both of these ones will depend with your country or the protocols in your country. Then surgical delivery, basically we advocate that mothers go for cesarean section where there is an absolute need. So we can perform emergency cesarean section for mothers who get complications such as obstructed labor, uterine rupture, among other issues. Then the third critical support, something our patients may need the intensive care units on the condition warrants. So in this case, to ensure that we have intensive care units in case our mothers require that critical care. So timely treatment saves life, but remember that we can never treat if we have not diagnosed. So it means that we, the healthcare providers, need to be very critical in recognizing the issues of the mother so that we're able to give the evidence-based interventions that need to be given. Next slide. All you are done. However, sorry for that. However, in Kenya as well as in East Africa, we have various issues that are basically hindering us from getting to where we are. So number one is workforce crisis, whereby we have severe staff shortages, especially in the rural settings. We also have burnout in the maternity ward, basically because we find that we have very few midwives and nurses caring for the patients. And basically these can interfere with the quality of care as well as the standards of care that are being provided. We also have resource limitations. So basically we are talking of us providing that basic emergency obstetric care as well as that comprehensive emergency obstetric care. But you find that in some facilities, especially in the rural settings, we are lacking the equipments that are needed for us to be able to provide that care. Then also we have inconsistent blood supplies. Remember that blood is one of the essential components of comprehensive emergency obstetric care. But we have patients dying because they are lacking blood. We also have limited ICU facility where we can take our patients. Then again, we have the operational delays, whereby we, the healthcare providers, are causing the third delay in basically giving care to our patients. Some of the issues basically find that there's delay in data access. For example, you find that this patient is in a low-level facility and maybe the nearest facility is kilometers away. So that distance basically creates issue in access. Then after reaching the facility, you may find that also we are having so many patients who need to use the same theater, which now causes again the third delay. Then again, we have protocol gaps where we have inconsistent adherence to evidence-based treatment protocols across facility, because some of the time we have the guidelines written in a paper, but now when you come to the implementation, some of the items that you need for implementation may be lacking. Some of the drugs that we are talking about using them, they may not be there. We are talking about the magnesium, so it may not be there. So basically that creates a protocol gap. Next slide, Anthony, please. However, hope is not lost. So innovations, we have different innovations and progress that have been made in Kenya. Like we are talking about the heat-stable carbetocin. So normally, you know that for oxytocin, we have to use the cold chain, but now we are having the heat-stable carbetocin, which basically can be used in the low-level facility, whereby we have no electricity or any other source of power. We're also having the digital health tools, for example, the AI-powered chatbots like Ask which the mothers can use to get reproductive health information. And basically, they're able to access care in good time because depending on how basically the responses they get, the chatbot can prompt them to seek care. Then we have the Linda Mama policy, basically which improves access of maternal health services to these mothers. Then also we can never forget the community health programs. Where we have now the community health promoters working in the level 1, that is the communities, and basically going to those mothers and encouraging them to go for ANC, and also referring these mothers in good time when they sense basically all is not well or when the mothers present with different danger signs, especially during pregnancy. So basically sorry, okay. So building capacities, it's okay, you can move forward, Anthony, no problem. So building capacity saves life. So what basically this means that we need to ensure that our healthcare workers have the capacity. And how do we do this? By ensuring that we do basically proper training during the pre-service phase. For example, in relation to EMOC, for example, when you are training the midwives and you are training the nurses, can we ensure that we are training them in the necessary competencies that are required, especially in emergency obstetric and neonatal care, so that they are able to save our mothers. Then once they get in the service phase, we are also encouraging that we do routine, continuous professional development, so that they're able basically to renew their skills, they're able to go get the updates that are there in relation to maternal and newborn health, and they're able to save our mothers. Next slide. So I think we are done. So most maternal morbidity, because we have seen they are preventable so long as we do what we are supposed to do. And we have also seen that early detection is very critical because it helps us to give the right interventions, and this improves the survival of our mothers. We also need to strengthen our healthcare systems, ensuring that our healthcare systems have the necessary resources, and also creating that enabling environment for our healthcare workers to be able to help our mothers. We also need to have those good referral systems, especially from the low-level facility to the high-level facility, so that for the facilities that are not able to give the comprehensive emergency obstetric care, these mothers are able to get that in the high-level facility. Then we should not forget respectful care to the mothers, whereby we are talking about respectful maternity care, whereby we should treat our mothers with respect, we should treat them with dignity. Yeah. Then every woman deserves a safe childbirth experience, and the knowledge tools exist, but what's remaining is scaling them equitably across Kenya as well as in East Africa, and also by strengthening the skills of our healthcare workers, by improving our healthcare system, ensuring that our health systems have the necessary supplies, and also never forget compassion. We can be able to reduce the maternal morbidity as well as the maternal mortality and protect the health and the dignity of our mothers. Thank you. I'm done, Anthony.
Thank you, Mirriam. That was a great presentation. I think you will both pick questions that are coming through. To our participants, if you have listened through, I think you might have some questions for us. So Dr. Paul is with us here, and Mirriam is with us here, who is an expert in this field. So please ask questions, ask away any question that you need. If you need not to type in the question and Q&A, and you are raising your hand and you need to say something or to ask live, please let me know. But we have the first question is, how do we curb home deliveries? And in case a mother delivers at home and comes to the facility, what do we need to do?
So thank you for that.
Sorry.
Oh, sorry. Go first.
No.
It's okay, Dr. Paul.
Oh, no. The first part of the question is, I think, our responsibility to educate our patients. Because a lot of women may not realize the risks that they are putting themselves and their babies to by doing a home delivery, especially on the first case. When I was doing my training, and I'm Canadian trained, it's not the same, but at that time in England, although they had allowed home births, and they had them, never for the first child, because you don't know until a woman successfully had a childbirth, whether they had problems which, um, you know, that necessitated, say, a cesarean section because the pelvis wasn't big enough for the baby to come through. So it was always, you have to come to the hospital for your first delivery. And I think it's our responsibility to educate our patients, not only in this area, but in other areas. And I don't know enough about practice in Kenya, and I don't know how often a woman would see a provider before they decided to undergo a pregnancy or to have a pregnancy, where the doc can say, or the provider can say, you know what, that's wonderful, but you've got to come to hospital with your first baby, because then we can prevent you having a problem. And then what do you do when they come with the child into the hospital? You're going to check that bum out, you're going to check the baby out, and assuming everything is okay, I don't see why the child and the mom cannot go home if the mom feels comfortable taking care of the child, and then you can give the mother advice as to, obviously breastfeeding, taking care of herself, etc. So, but maybe I could ask my colleague to pick up, and what else should we do?
Okay, thank you, Dr. Paul. I think what you said, basically, I agree with that, but I have a few additions. We also need to educate our mothers, basically, on knowing the signs of labor, so that basically they're able to seek care when they know basically they are getting the signs of labor. Then, in addition to that, we need also to have proper referral systems to ensure by the time they reach basically a healthcare facility, they are able to get into the healthcare facility in good time. And in this case, we are talking about referral from the community to a healthcare facility. And in the Kenyan context, we have the community health promoters that really help us be able to refer the mothers from the community level, and they're able to get to a healthcare facility as soon as possible. Thank you.
So it came with the same case. In the same question, there was, if a mother comes and has already delivered at home, what needs to be done in the facility?
So in the facility, if the mother comes and they have delivered at home, just as Dr. Paul has said, we'll do, of course, first examination of the newborn, that is the baby, as well as the baby is having any issues. Then again, we also do examination of the mother from head to toe, so also to know whether the mother is doing well. And what will be done after will depend with what you as the healthcare provider, you are able to pick from the mother and the baby at that time. Yeah, I think I've answered the question. Yeah.
Thank you. The next question is, which cases is a mother high risk, and when are you advised to refer to higher level?
High risk in pregnancy, in labor, or in general?
I guess the question is in general. When I guess what the attendee wanted to ask is, at what stage, in the lower level, let's say in a dispensary or health center, at what level do you decide this patient is not to be taken care in the facility that you are in, and then refer to higher level?
So thank you for that question. It's a wonderful question. So I think the decision for you to refer, number one, will depend with what you are able to do at the facility that you are in, depending on whatever that is available to you. Because most of the time we refer because we don't have the capacity to manage that mother at that level. So that is number one. Number two is also depend also on the competency of the healthcare workers who are there. For example, you can find in a low-level facility, you may lack a medical officer who can do the cesarean section, and this mother needs that. So in this case, if that skill is missing in that level facility, and this mother needs that, it means that we need to push this mother into the next facility where they can get that emergency cesarean section. So all I can say is it depends without the mother presents, whatever you have as a healthcare provider in terms of the workforce as well as the resources that you have is what will determine how and when can you refer.
Thank you. The next question comes from Dennis. He's asking, in case of a postpartum hemorrhage that has happened and you have already given oxytocin 10 international units, and it is mispressed for direct or 800 micrograms, what would you advise the patient next?
I've lost you. I've lost you. Can you pardon, please?
Yeah, can you hear me now?
Yeah, I can hear you clearly.
Okay, the question was in case of a PPH, that's a postpartum hemorrhage that has happened, and you have already given the patient 10 international units of oxytocin and misoprostol per recto 800 micrograms. What would you advise next?
So I think number one is also determining the cause, knowing why are we getting the hemorrhage, looking for the 40s, because whatever that you do next after that will depend on your 40s. Are you treating tears? Are you treating retained tissues? Are you treating thrombin or clotting disorders? Yeah. So I think identifying the cause will be very critical because that will basically determine your next line of management. Are you treating atonic uterus? Yeah. And
Yeah,
maybe Dr. Paul can add something.
Dr. Paul, are you there?
Yeah, the drug of choice after for postpartum hemorrhage is obviously oxytocin, and the next one is tranexamic acid, tranexamic acid, and that's recommended as an adjunct, and it's ideally given within 3 hours after the delivery, as it significantly reduces the mortality without causing any adverse events. So and that's you now. The only data I have is from the US. I don't have, and I don't know what's available in Kenya. So I hope the answer is that medicine available in Kenya?
Yes.
Okay, so that's number two as an adjunct.
Yeah, I think I will help too in that, Dennis. The most common thing that we do as you start the misoprostol and and oxytocin, and then start on tranexamic. We give 1 gram IV. If I'm not wrong, we give 1 gram IV for 10 minutes and
Right,
within
exactly.
3 hours of birth. If I'm not wrong,
Mhm.
good.
Right.
And then the next thing, actually, you should never forget is what's causing the PPH. As Mirriam has said, we have to turn tissue, trauma, and thrombin. If there's tissue retention, make sure that you have evacuated every
Right.
tissue. If there's a tear, start prepping for surgical for surgery. And then if in severe cases, that's when we have a balloon tamponade. We use a balloon to 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 hold the uterus. But that's in severe cases. If you go to if you work on the 40s, you will come up with the reason this person is having a PPH, and then you will manage according to the 40s. But the first one is always oxytocin, and then, as you have said, misoprostol, and then the third one is tranexamic acid, 1 gram over 10 minutes or 3 hours after birth. That's how we work with it. So in case it goes past that and you have tried to figure out the 40s and then you're not getting, start prepping for referral and an emergency laparoscopy.
Right.
The next question, in cases
Did we do the question about the when at what case do they which cases is a mother at high risk and advised to refer to a higher level?
yes.
Okay. The only other thing I just may add to that is two part knowing what you have to know your capabilities and your facility's capabilities. I mean, and that goes almost for any part of medicine. If a patient presents and I'm not sure what to do, I'm a family doctor, a primary care. If I'm not sure what to do next, that's when you do a referral. Or if you look in this case, if you look at your facilities, you say, given the risk status of this patient, can my facility handle the potential complications? And if the answer is no, then of course you want to refer before you try to do something and the woman runs into problems. So I think that applies to all of medicine, not only obviously this.
Thank you, Dr. Paul. And I think everybody should know that referral is part of treatment. So don't ever forget that. When you refer a patient, you're helping the patient. It's part of your treatment management. Fluids too, don't ever forget about fluids. As you are saying, PPH, even if you don't have blood in your facility, start working on having a large ball line and start infusing the patient so that by the time they go to a higher facility, you have already started the simple management. The next question, and I think this will go to Mirriam. In cases a mother is HIV positive, what's done different from a mother who is HIV negative?
Okay, I think the management starts from pregnancy. So during pregnancy, for mothers who are HIV positive, we highly recommend that these mothers adhere to the antiretroviral treatment so that at least we're able to achieve viral suppression or we're able to lower the viral load. And then if we talk about the HIV negative mothers, during pregnancy, we recommend at least we test them during the first trimester as well during the third trimester of pregnancy. Then for the ones who are negative during delivery, we also want to repeat it. We want to repeat it 6 weeks after, and then we want to do it every 6 months so long as the mother is breastfeeding. Then the protocols now during delivery, they vary from Kenya and US. In the US, you don't breastfeed if you're HIV positive, but now in Kenyan context, we encourage exclusive breastfeeding for our mothers for 6 months. And then after that, we can do the complementary feeding. Then again, for the HIV exposed infant, we usually give zidovudine plus nevirapine for 6 weeks. Then after that, we give nevirapine so long as the baby is breastfeeding up to 6 weeks after complete cessation of breastfeeding. Then for the mothers who are HIV negative, we just start routine testing them during delivery at 6 weeks, at 6 months, and then we are doing it every 6 months so long as the mother is breastfeeding. Then for the child, for the HIV exposed infant, we're also doing the PCR test. So we recommend that we do the first PCR as early as possible. You can do it at birth if possible or first contact. Then we can do it at 6 weeks. We do it at 6 months again. We can do it at 1 year. And then during 18 months, we can do our first antibody testing that at this point now the antibodies of the mother will have cleared from the child's system. So if the child is having the HIV antibodies, these are his or her antibodies. So I think that answers your question.
Yeah, I think that answers the question. And mostly, I think to add on that, as Dr. Paul takes over, mostly what happens is general. Don't ever stigmatize a patient that is HIV positive. They are treated the same. They something that we might not forget. We do cervical cancer screening to these mothers. It's even if they are not pregnant. So always make sure that because they are prone to cervical cancers. So always make sure even before they come to the facility and report they have they are pregnant. Please make sure that you are always doing cervical cancer screening to all mothers, and that will work in tandem with making sure they don't have a problem later when they get pregnant. Dr. Paul, any addition?
Then I have an addition to make, Anthony. I've just remembered something. Can I say it?
Yeah.
So again, I've also remembered during labor and delivery for the HIV exposed infants, whereby the mother is positive and the child is born from a HIV positive mother, during the normal labor and delivery, usually discourage the routine suctioning. We also discourage milking of the cord. We also want to shorten the delivery time if the mother delivers normally. But most of the time, usually advocate if the mother is not virally suppressed, we recommend that these mothers deliver through cesarean section. Then also we discourage the routine suctioning of the baby. We also discourage the application of the electrodes for people who are using the electromonitoring. Then also something else that we discourage, we also discourage the instrumental delivery and also the application of vacuum extraction for these children, so that they can reduce their chances of getting the HIV from the mother. Thank you.
Yeah. I think that's all from that question. The next question is, I joined late, we work in the community. What does one use when they encounter an hypertensive mother? before we refer? What medications can be given to a pregnant mother that is hypertensive?
The two drugs of choice are labetalol and extended release nifedipine. Those are the two safest medicines to use with the minimal, risk to the child and the best protection for the mother. That's the U.S. guidelines, and I'm sure yours will be pretty well the same.
Yeah, so I will help on that too. The common one actually in Kenya is methyl-dopa because of the long-term use. It has been proven safe in pregnancy. But labetalol, and I think the issue being labetalol is somehow expensive in the market. For a 5 milligrams tablet, it costs, if I'm not wrong, it costs nearly 70 shillings. That's nearly $1 for every tablet.
Oh, wow.
Yeah, so it's somewhat expensive. But nifedipine oral, it's cheaper because it's 5 cents in USD, but 5 shillings in Kenyan money. So it's cheaper. But the common one that they use is methyl-dopa or nifedipine. The problem now sometimes with nifedipine, some patients complain of headache. They complain of headache so much when they use nifedipine. Something that we discourage is the discourage of use of AC inhibitors. Don't use the AC inhibitors, the enalapril, the lisinopril, and don't use losartan too. That's the ARBs, the angiotensin receptor blockers. And lastly, don't use spironolactone. Those are anti-androgenic. They have an anti-androgenic effect. The most common one that you'll find is methyl-dopa, starting with the 250 milligrams to 500 milligrams, sometimes twice or thrice daily, according. And nifedipine 2 is effective to patients that don't complain of headaches, but avoid ARBs and CCBs. Please avoid ARBs and ACEs, not CCBs, and ACEs. And this one will help the patient. And sometimes even because of preeclampsia, magnesium sulfate is the common one, is the drug of choice, and then control the BP with labetalol, hydralazine, or nifedipine in these cases. Nifedipine, 25 milligrams infusion, I think, if I'm not wrong, but the most common one that you will find is nifedipine to control in a preeclampsia case, and then start on magnesium sulfate. I think I'm not wrong on that, Mirriam.
Yeah, you are right. You are right.
Okay. Yeah, I was trying to pull everything out of my head. The Kenyan context. In the Kenyan context,
Yeah.
I try to work with the Kenyan context. So we have Shellington here. Thanks for amazing presentation. Between oxytocin and capetosin, what is the drug of choice for PPH according to you? This will go to either Mirriam or Paul.
What is the drug of choice for what, please?
For postpartum hemorrhage, between oxytocin and capetosin.
Yes. Yeah, I thought we just answered that. Maybe I'm wrong.
Yeah, we did. We said that oxytocin is the drug of choice because the capetosin was used due to the cold chain because you don't need a fridge. In some areas, because of the stability of capetosin, it is used in areas that in low settings of hospitals that don't have the capability of the cold chain. If I'm not wrong, correct me on this, Mirriam, but oxytocin is easily available and readily available and very cheap in the Kenyan market. And I think in the East African market, if I'm not wrong. Mirriam, I think I've helped on that. If I'm not right, please correct me.
So I think me personally, I've only used oxytocin. I've not used the capetosin, so I may not have much to say on the capetosin. Yeah.
Thank you. Yeah, if you in cases that you would like to know how capetosin is used, it's mostly in the northern part of Kenya, where there's high temperatures, and sometimes the delivering drugs to these areas takes a lot of time. So you need vehicles that have cold chain, and sometimes it's so hard to access them. So carbetocin is stable at room temperature. So it's so easy to transport and use in those areas. But in areas that we live in, that we have cold chain and monitoring is so easy, what we call the KP, it's so easy for them to use oxytocin. The next question is, what cases do you decide to stop a normal delivery and opt for cesarean section?
I think this can be divided into two categories, absolute and relative. So absolute is a complete placenta previa. If the placenta is blocking it, you're not going to try and do anything. If you think the uterus is rupturing, that's an absolute. If you think that there's a transverse lie for the baby, the fetal position is such that's not safe. So these cases, yes, automatically. And then there's a relative risk. For example, if you're noticing a change in the baby's heart rate, which you're concerned that the child is at risk, in that case, you have to assess the child. And if you're going to deliver relatively quickly and you think that heart rate and you're monitoring it, it may be okay, or you can elect to do cesarean section. Also, if you have a breech delivery, if you're some places still deliver breeches vaginally, other places no, it's an absolute indication for cesarean section. And I think partly it depends on what you have as options and the skill of the operator. If you have twins or a number of child there, that may be an indication. It's not an absolute, it's a relative indication to see, do you want to do a cesarean section? And if a woman has had a previous cesarean section and you're worried that the uterus itself, the pregnancy itself and going through the delivery is going to cause too much stress on the existing scar. And we used to say, at least when I started my training, automatically you had a cesarean section, but more recently it's different. You can say, and again, this all depends on closely monitoring your patient. If it's an absolute, yes, you do the section. If it's relative, you can change your mind along the way. If you start monitoring that baby's heart rate and you're concerned that it's going too slow, okay, you switch and you do an immediate cesarean section. If the baby seems okay, you can proceed and you may be able to do a vaginal delivery. And maybe we can get Mirriam's extra help on this.
I think what Dr. Paula said is basically what I just wanted to say. However, I can make a few additions. Most of the relative indication is basically upon you, the healthcare provider and the patient, really decide. For example, we are having issues, for example, like preterm labor. Yeah, but basically what he has said. I don't think I have any other addition. I'll be echoing what he has said if I say it again.
Thank you. Why is the use, there's a Felix question here, why is the use of normal saline fluid discouraged during labor?
Do we discourage or encourage?
He's saying it is discouraged.
So the time, for example, when we are having, for example, we are getting fetal distress, most of the time that is what we usually give so that we are able to increase the placental perfusion and be able at least to improve the fetal heart rate. We encourage it, especially if we are having fetal decelerations. We give the normal saline to improve the placental perfusion. We don't discourage. Unless, I've never heard where we are discouraging.
Dr.
We
Paul?
encourage
Yes.
to use it.
I would have to look that up more because I thought I don't have a good answer. I'm sorry.
So I think the most question, the most, I think I've had these it's not a routine thing that has always been in the market, but there's a study that says it has a high chances of causing postpartum hemorrhage because I think it reduces the tone of the uterus. The second thing, I think it causes the electrolyte imbalance due to the high levels of sodium. If I'm trying to figure out the times that I've heard of that. But if you have ringers, I think Felix where is going, if you have ringers lactate, it is the most advisable one to use rather than normal saline because of the difference in probability of causing different issues during delivery. But it's something that I think Dr. Paul will go and research and come back with an answer.
I certainly will.
Thank you. We have 2 questions and then we are done. In a case scenario, a client presents with a 3 months pregnancy, which is still intact after trying to abort, yet no bleeding. We are now worried about the pregnancy. Will the baby grow to term without any deformity after a failed abortion?
If you look, the fetal risk for failed self-induced abortion depends what the woman tries to use, and if they're trying to use a pill, and that fails, you have the risk of congenital anomalies is one of the risks. The second is for preterm birth, low birth weight. Of course, there's an increased risk of neonatal death. And of course, depending what the woman tried to use, there's a risk of infection or internal injury. So, there definitely are risks. And partly is what did the woman or whoever tried to induce the termination do? So I hope that answers it.
Yeah.
And partly, I don't know if there's any really good studies that look at women who try to do this. I'll try and find out if there are good studies to say, where they've identified women who've tried to have an abortion that's failed and what happens. And I'll give an answer. I'll provide that. And also I don't know if everybody here knows, all these slides are available to all the listeners, and we can make all these available. And I'll send out the answer by tomorrow to Anthony, and then he'll distribute it to everybody for the research that I can do for that.
Okay. I think, Dennis, that will be answered and we will send you more. But I think something that I've come to understand is that if there's nothing that has happened, if there's no bleeding, there's no pain, there's just monitor the mother. And then, as you know, how we know fetal distress is, and in cases the child reaches, and I think we start with the 16 weeks to 20 weeks. That's when we start getting fetal heart rates. Then if they are not there, do continuous ultrasounds, and then you will figure out whether the baby survived or not. But it's not something that you can come to a conclusion and say, this happened, it did happen or it did not happen when there's no bleeding or when there's no pain.
Right, for sure.
So there is a question by Shalington, the last question. Before we close, I think we have 5 minutes per time, but we'll try our best and answer it. Labetalol is expensive and is not suitable in our setting. Mainly used to stabilize high blood pressures. We prefer nifedipine or methyldopa, but methyldopa is mostly used. I think Shalington was just echoing what I pointed out, but methyldopa is the most common one that is used in our setting, between 250 milligrams and 500 milligrams, and it has been shown to work very well in the low-level settings because it's so cheap. As we have said, labetalol is so expensive that some mothers can never afford it, and some areas it is not paid by insurance. Something else to add before I give Mirriam and Paul the room to finish up is that Linda Mama is not in function currently, But the new social health insurance fund is trying to take over that part, although it has not yet taken over fully. Linda Mama came to an end 2 years ago, but currently the social health insurance fund is trying to take over deliveries and pregnancies, so that if you are registered in the social health insurance fund, I think it's something that is taken care of. I'm not sure about that, but I think what I'm sure of is that Linda Mama came to an end years ago. So the slide that indicated about Linda Mama, we have a new social health insurance fund that is taking care of that. Thank you all. I think I will give Mirriam and Paul to give us the last words before I give John, our ED, room to close or to adjourn the webinar for us.
Okay, thank you, Anthony.
Oh, I'm sorry, Mirriam, please go ahead. I'm sorry.
It's okay, no problem, Dr. Paul. So to the participants, thank you for joining us today and also for your active engagement by asking questions. So what I hope is that the insights that we have shared will remind us about the things that we can do in the spaces that we are in to improve maternal outcomes, and also basically to improve our commitment to ensure that we save the lives of our mothers as well as their newborns. Then also I hope we carry the lessons that we have learned forward in the spaces that you are in, basically ensure that you do whatever that is possible within your capacity in terms of maternal care and also neonatal care to ensure that at least these maternal deaths are going down. And also a special appreciation to the organizers, and also Dr. Paul, my fellow presenter, and also all the participants for making the session a success. Let's continue working together. Let's continue innovating and basically improving maternal health care in Kenya and beyond. Thank you all, and thank you for listening to me as well. And also thank you for the opportunity. I'm humbled. Thank you. Back to you, Anthony.
Thank you, Mirriam. Dr. Paul?
Well, first of all, I want to thank Mirriam. We've been doing this for a little while. This is wonderful that Mirriam is presenting. Hope she'll continue. We worked on this together, and I think that made it all the more relevant because, as you know, I'm in the US and Mirriam has the experience hands-on in Kenya, which made this a much more valuable presentation. Also, I keep asking, please, if there are topics that the listeners want to hear about, please let Anthony know. He'll relay it to me, and then we can work on getting a presentation to try and help with that topic. But thank you very much for coming, and for all the care you render, of course, to your patients. Thanks, Anthony.
Thank you. Before I give John, our ED, the room to close the meeting, my email is anthony@addisclinic.org, ANTONY@addisclinic, addisclinic.org, addisclinic.org. My phone number is 0712-559-438. So if you want to reach out, know about our telemedicine program, know about more about our programs, please reach out to me. Our website is www.addisclinic.org. Please go check out our website. If you have any topics, if you have any more questions that you need, shoot them to me, shoot them through my email, call me, WhatsApp me, and I will forward them to either Mirriam and Paul. And then the questions that were not responded today, we will include them in the next. We will send out within the next 1 week. Please, thank you for attendance. I yield my time to John to close for us.
Thank you to our expert panel on this important topic. Really appreciate the time that you have put into this, and thank you to all the attendees and your thoughtful questions. And do reach out if you have any ideas for future webinars, and hope that everybody in East Africa there has a good night, and we'll see you guys next time. Thanks.
Bye-bye, everyone. Have a good evening. Have a good afternoon to you all. The webinar is adjourned. Bye-bye.